This is Dr. Lori Gardner, and this is Substance Use Disorders, Part 2 for Nursing 591, 691, Nicholls State University. So let's start off by talking about assessment. The gold standard for effective treatment begins with an accurate and comprehensive assessment, diagnosis, and early intervention. Diagnostic criteria can be found in the DSM-5 TR. Some complicating factors: substances used previously and currently, the pattern of use, which is the quantity and frequency, the current level of adaptation, contributing factors, their perception of use. Substance use and substance dependence are commonly seen in medical settings, and are frequently comorbid with other medical and psychiatric disorders. So we see a lot of substance use disorder being treated on the medical side. So you may not be tested as much on substance use because it is also on the medical side. Now that's on certification. For this course, remember, you have an outline and a blueprint, so you will have some testing on substance use disorder. There's a considerable social stigma that exists towards patients with substance use disorders. Healthcare providers frequently have negative attitudes towards these patients as well. Fortunately, you can master communication skills that will facilitate the establishment of a therapeutic relationship and help motivate patients for treatment. There may be signals that raise concern about a patient's substance use in an interview, during the physical exam, in prior records, or in statements from significant others, office staff, or hospital staff. These red flags should be an indication to follow up with the same diligence and persistence as you would after a positive drug screen or disclosure of heavy substance use. Some red flags: alcohol on the breath, ascites, an enlarged liver, nasal ulcers or a perforated septum, excoriated skin from scratching, track marks, skin abscesses, obesity or anorexia, abnormal gait, tremors, mood swings, slurred speech, changes in pupil size, chronic pain, injuries, blackouts, accidental overdoses, withdrawal symptoms, and some other GI problems, premature labor, or vague somatic complaints, emotional lability, irritability, and insomnia. So the Clinical Institute Withdrawal Assessment Alcohol Scale Revised, which is CIWA-AR, has some symptoms that you can ask about in your assessment, like nausea and vomiting, diarrhea. Do you feel sick to your stomach? Have you vomited? For tremors, arms extended and fingers spread apart so you can see if your patient is having tremors. Any auditory disturbances, like, are you more aware of sounds around you? Are they harsh? Do they frighten you? Are you hearing anything that is disturbing to you? Are you hearing things you know are not there? For visual disturbances, does the light appear to be too bright? Is its color different? Does it hurt your eyes? Are you seeing anything that is disturbing to you? Are you seeing things you know are not there? For anxiety, you can ask them, do you feel nervous? Any headache, any fullness in your head? Does your head feel different? Does it feel like there is a band around your head? Are they having any paroxysmal sweats? For headaches, don't rate for dizziness or lightheaded, not with headaches. Agitations. Are they pacing back and forth during most of the interview? Are they constantly thrashing about? Um, would you rate their orientation? How would you rate that? In cloud, is there any cloudiness? Ask what day it is. Where are you from? Who am I? Especially if they've met you before, right? Some of the consequences, they may have psychiatric symptoms, social problems. So, what kind of psychiatric symptoms might we see? Anxiety, flashbacks, depression, hallucinations, maybe some memory and concentration problems. They might be defensive, right? And socially, they might be isolated or withdrawn. They may have a loss of their previous friendships. They may have some marital difficulty, including intimate partner violence. It may be loss of interest in their prior activities. For education and employment, they may be failing out of school or having poor grades. Maybe they're losing a job, or you notice they have frequent job changes. There could be some legal problems like driving under the influence, involvement in assault, either as the perpetrator or the victim, or other violent behaviors, stealing, drug possession, prostitution. With their family, it may be positive for substance or mental use disorders, as well as developmental problems in children. So, alcohol dehydrogenase um, metabolizes alcohol, and women have less compared to men. So, women get intoxicated easier due to decreased dehydrogenase. Oops, let me go back. And also, women have a higher risk of having liver problems if they drink due to that decreased dehydrogenase. Some screening tools that can be used. The audit tool, which is a 10-item self-administered and it's widely used for detecting risky and harmful drinking patterns. There is the CAGE questionnaire, 4-item self-administered. A score of 2 or more is clinically significant. And the CAGE is one of the oldest screening tools we have. It's relatively non-confrontational for detection of alcohol, usually phased or phrased as "Have you ever?" But it may be focused to delineate past or present alcohol problems. The CAGE asks about lifetime experience rather than current drinking. So a person who no longer drinks may screen positive unless the clinician directs the questions to focus on a more current time frame. 2 out of 4 or greater is a positive CAGE, and further evaluation is warranted. The CAGE aid is a 5-item self-administered, and it screens for alcohol and drug use. The audit is a comprehensive 10-question alcohol harm screening tool. It was developed by the World Health Organization and is used in a variety of health and social care settings. The screening tools only identify alcohol use disorder and does not predict the likelihood or severity of any alcohol withdrawal symptoms. So on the audit, 0 to 7 is a low risk, 8 to 15 is increasing, 16 to 19 is high, and 20 or more is a possible dependence. So in giving feedback and advice, if the score is lower, I'd say lower than an 8, Give them brief advice to reduce alcohol harm. If it's 20 or above, consider referral to a specialist like an alcohol treatment facility. The Clinical Opiate Withdrawal Scale, or the COWS, it assists in quantifying the degree of opiate withdrawal, useful in preventing precipitated withdrawal. The COWS is an 11-item scale, and it's developed to assist clinicians in quantifying the degree of opiate withdrawal during their patient assessments. Opioid withdrawal intensity relies on both the severity of physical dependence and opiates and the relative occupancy of the opioid receptors at the point of assessment. So the COWS score measures acute opioid withdrawal and is a useful tool frequently applied for Suboxone starts before it started. The interpretation is either no active withdrawal, mild opiate withdrawal, moderate, moderately severe, or severe opiate withdrawal. Some diagnostic tests that you can perform on your patients with CBC, because it will check for anemia from chronic gastritis. Of course, a low hemoglobin hematocrit or red blood cells indicates anemia. An elevated MCV is a macrocytic anemia. They may have B12 and folic acid deficiencies, so check their B12 and folate levels. You also want to check a comprehensive metabolic panel like their liver functions. Remember, ALT and AST is elevated with chronic alcohol use. You want to check their renal function and bilirubin. Again, AST, ALT, and MCV indicates long-term heavy alcohol use. Thyroid function test, Hep C and HIV testing, urine drug screening. So you would do that at the very beginning and routinely during treatment. And neuroimaging, you can order an MRI or an EEG. However, I would refer them and have the specialist order those tests unless you plan to treat. Because if you're going to refer them out, that specialist is going to want their own MRI or EEG. So let's talk a little bit about treatment and relapse prevention. So when we are discussing treatment, has the criteria for dependence been met? Why are they seeking treatment now? Is it because they are ready for treatment? Is the court telling them that they have to come? Is it pressure from family? And if they've had treatment before, how did they respond to it? What kind of treatment did they have? And then discuss their goals, short term, medium, and long term. Some short term goals may be, I just don't want to drink tonight. Long term is, I want to stay abstinent. I don't want to drink anymore. So discuss those goals. And of course, it's patient centered. So there's no cookie cutter. It depends on the patient. Provide a roadmap to recovery, provide structure, should be outcome driven, well-written individualized treatment plan that should be reviewed, approved, and signed by the patient. That is important. Your patient has to agree to this plan or they're not going to follow it. Treatment plans with progress notes addressing each section, incorporating their goals and their objectives. So why are treatment plans important? Because it's going to provide structure, a roadmap to recovery for your patients. It's very important, especially for patients who have experienced a chaotic lifestyle. You help the patient and the clinician remain focused on the purpose of the treatment. Some non-pharmacologic treatment and recovery. Some tips for minimizing the risk of relapse. So factors that support their recovery, their roles in their relationships, being in a safe, healthy environment, being recognized for their efforts by any others, family members, healthcare members, having that support and psychoeducation, having support during a crisis, and of course, lifetime treatment is often required. They should get enough sleep, eat a healthy diet, avoid any type of disturbances. Make sure that if they're seeking help, they're being honest and they're adhering to the rules, and they're going to modify any potentially maladaptive behaviors. There's 4 dimensions of recovery, and that includes health, home, purpose, and community. Therapies include individual therapy, group therapy, and of course, CBT. Medicated assisted treatment, or MAT, for alcohol use disorder, there is Antabuse and Campril. For alcohol and opioid use, naltrexone, and for opioid use disorder, there is buprenorphine and methadone. The FDA has approved several different medications to treat alcohol and opioid use disorders. MAT medications relieve the withdrawal symptoms and psychological cravings that cause chemical imbalances in the body. Medications used for MAT are evidence-based treatment options and do not just substitute one drug for the other. Acamprosate, disulfiram, and naltrexone are the most common medications for treating alcohol use disorder. They do not provide a cure for the disorder, but they are effective for those who participate in MAT programs. These medications improve patient survival, increase retention in treatment. For opioid use disorder, they decrease illicit opioid use and other criminal activity among people who have substance use disorders. They increase patients' ability to gain and maintain employment. They improve birth outcomes among women who have substance use disorders and are pregnant. The goal of MAT is full recovery, including the ability to live a self-directed life. Let's talk a little bit about disulfiram, or Antabuse. Its mechanism of action is that it inhibits aldehyde dehydrogenase, leading to acetaldehyde accumulation when alcohol is consumed. Remember, if they consume alcohol while they are taking disulfiram, they will feel deathly ill. Some of the side effects that are common are headaches, metallic taste, drowsiness, and impotence. Serious but rare would be hepatitis, neuropathy, and psychosis. They must avoid all forms of alcohol, including hidden sources, as consuming alcohol can lead to a severe reaction. So that's alcohol in any over-the-counter mouthwash, any medications where there contains alcohol, drinking, rubbing alcohol, any alcohol, they need to avoid it. The dosing is 500 milligrams daily for 1 to 2 weeks, followed by 250 milligrams daily for maintenance. It is initiated after a period of abstinence. It is contraindicated in severe myocardial disease and/or coronary occlusion, psychosis, or any known hypersensitivity to the medication or other Xyrem derivatives. So avoid this medication in nursing and pregnancy. Emphasize that the use of alcohol will result in nausea and vomiting and other severe side effects, including psychosis. No alcohol use whatsoever when taking disulfiram. There is a black box warning for this medication. Acamprosate, or Campril, this medication is an NMDA antagonist, it reduces cravings, supports abstinence. Whereas disulfiram creates more of an aversion to the medication because the patient is not going to drink knowing how sick they can get. Some side effects of acamprosate common side effects include diarrhea and nausea. Some less common would be anxiety and insomnia. It's generally well tolerated, but if someone has kidney problems, they may need dose adjustments. But if they have severe renal failure, do not use this medication. One of the problems is compliance because this medication is taken 3 times a day. So 666 milligrams taken 3 times a day. You do have to monitor lab work when a patient is taking this medication. Monitor their health status and caution the client about the side effects that are listed and encourage that they stay well hydrated. Topiramate. This drug should not be stopped suddenly because of a high risk of relapse. It facilitates GABA-mediated current at non-benzodiazepine sites of GABA receptors. It is an antagonism of alpha-amino 3 hydroxy 5 methyloxide 4 propionic acid receptor. Am I going to ask you to know that? No. Some of the side effects of topiramate: fatigue, headache, dizziness, depression, and weight loss. Some less common but more disturbing would be paresthesias and cognitive impairment. The client should be monitored and checked for side effects and the accurate self-administration of this medication. Initiated at 50 milligrams a day, increased to 150 twice daily, which is the max, and they must taper off of this medication. They should not stop it suddenly because of the high risk of relapse. Naltrexone, that is an opioid receptor antagonist. It reduces cravings and blocks rewards affecting alcohol. Some of the side effects include nausea, headache, insomnia, and fatigue. They must be opioid free 7 to 10 days before starting it, and you will have to monitor liver functions. This is dosed as either naltrexone, which is Revia, 50 milligrams daily, or it can be taken by injection, which is Vivitrol. Buprenorphine, that is a partial opioid agonist. It binds to mu opioid receptors but has a ceiling effect on respiratory depression. So they're less likely to die by overdose. Some of the side effects include headache, anxiety, constipation, oral mucosal irritation, and sleep disturbance. Induction when in mild to moderate withdrawal, or 6 to 12 hours after the last use of a short-acting opioid, or 24 to 72 hours after a long-acting opioid. Initial doses may include buprenorphine and naloxone, which is Suboxone, or buprenorphine alone, and maintenance varies based on their response. Methadone. It's a full opioid agonist and it activates mu opioid receptors. May cause some constipation, sweating, weight gain, respiratory depression. This one is high risk and overdose. You see, it can cause respiratory depression, unlike Suboxone. Of course, you won't be prescribing methadone unless you're working at a methadone clinic. Some special considerations are the QT interval prolongation. There is a risk of overdose if misused. Regulations would be the administration of this medication. You will not give methadone and Suboxone to a patient at the same time. Dosing is in a controlled setting. Titration is based on withdrawal. Remember, you're not going to give this in a regular clinic setting. This would be done in a methadone clinic. Naloxone is a rapid reversal of effects of opioids by competitively binding to opioid receptors. It is used for acute opioid overdose reversal. It has limited side effects when administered for opioid overdose reversal, rapid onset and a potential for acute withdrawal. It can be given IM or by inhalation. Recently, just like maybe 2 days ago, there was an episode where a male patient was given naloxone in I think it was Walmart or Rouse's parking lot on Chapatulas, and a police officer gave him naloxone. He woke up out of his mind, got into a car, drugged the police woman down the street. She did have to fire her pistol. From what I understand, he did not survive, but he woke up acutely and was in some stage. I'm not quite sure what happened, but the police woman was injured. It was recently on the news, and this happened in New Orleans. For alcohol withdrawal, okay, we're going to talk about the levels next, but the Clinical Institute withdrawal assessment, and we talked about that already, so I'm not going to go over it again. But I do want to talk about alcohol levels. Blood alcohol levels can be affected by other substances like medications or drugs. Understanding the levels are essential for assessment, and you should know which levels require inpatient observation or admission. So if your patient comes in and they have a 21 to 50, they're mildly intoxicated, probably have some impaired coordination and judgment. You might want to watch them, for safety for a little while until they sober up. If somebody is greater than 80, they're severely intoxicated, probably have a loss of balance and vomiting. Probably not somebody you're going to send right home, right? They're severely intoxicated. Somebody with 101 to 200 is extreme. They're probably having a coma and seizures. They're probably going to critical care. Anybody over 200 is life threatening with alcohol poisoning. But just know at which level would you consider admitting or sending home. Okay, so some scheduled medications for alcohol withdrawal. Diazepam, which is Valium, is preferred. Lorazepam, which is Ativan, if their LFTs indicate liver damage. There's Librium. Avoid that one in liver or renal disease and avoid in older adults. Benzodiazepines are useful for alcohol withdrawal. However, if the patient has narrow angle glaucoma, you'll have to explore other treatment options, especially the older population with narrow angle glaucoma. They're generally safe for most people, but again, they pose a risk for individuals with narrow angle glaucoma. These medications can dilate the pupil, which can exacerbate the condition by potentially blocking the eye's drainage system and increasing pressure. So, while studies suggest a possible link between benzos and an increased risk of acute angle closure glaucoma, especially in the elderly. So, be very careful. And remember, alcohol detoxification is only managed in residential treatment facilities, it's not outpatient. But knowing about narrow angle glaucoma is beneficial even if you are in the outpatient setting and you're considering giving benzodiazepines to an older patient. Relapse prevention, addiction treatment addresses 4 dimensions. We talked about that earlier: health, home, purpose, and community, all through a holistic approach. So, permanent housing, social inclusion, having a purpose like work or school, for health, recovery, health, and wellness. And this encompasses the patients and their families. Some behavioral interventions target internal and external reinforcers like their motivation to change, attending group therapy or individual therapy, self-help recovery groups like AA, aversion therapies like disulfiram, family involvement in therapy. There's 12-step programs, contingency management. The goal is relapse prevention. Planning for change through motivational interviewing is goal directed. We use the trans theoretical model of change. The client should be motivated. Our process should be non-confrontational, and we should ask open-ended questions. So focused goal-directed therapy builds on the trans theoretical model of change. Motivation is elicited from the client. It's non-confrontational. Of course, we ask open-ended questions to get the patient to think before they respond. Listen to the patient with a patient-centered approach. Be very empathetic. Empower the patient. The patient must understand that they are in control of their actions, and any change that they desire is going to require them to take the steps towards change. Affirm the patient's positive traits. Use reflective listening techniques while the patient talks about their disorder. And remember, open-ended questions, affirm, redirect, and summarize. That's the OARS model. So there's the different steps, and this should be just a review. There is pre-contemplation, contemplation, preparation, action, maintenance, or relapse. Actually, you're going to have this a little bit more in 592. So we're just touching on this briefly. That is the stages of change using the trans theoretical model. And again, we will go over this in 592. So there's stages of relapse, which is there's emotional relapse where there's no thoughts about having a drink or using drugs, but they are starting to neglect their self-care. There is mental relapse where there's an internal tug of war going on. They're starting to have cravings for alcohol or drugs. They're having nostalgic feelings for people and places and things associated with alcohol and drug use. And they may lie to themselves about the consequences, like, you know what? I can have one drink. I'm going to be able to tolerate it. I'll be fine. It's only one drink. And then there's physical relapse where they're drinking and or using drugs again, and it quickly escalates into an uncontrollable level. So, what about relapse prevention, the recovery model? Treatment approach emphasizes resilience and control over problems in life. The recovery model aims to help with mental illness, looking beyond survival and existence. It supports views that develop relationships and give life meaning. Follow your dreams. Recovery is about recognizing and fostering abilities, interests, and dreams. It's self-directed, it's individualized, and person-centered. Remember, it's not cookie cutter. And recovery is based on continual growth, occasional setbacks, and learning from their experience. It is not a linear process. Okay, and that is the end of substance use part 2, because there were a few things that I wanted you to hear. So if I took the time to record this, there is a reason that I recorded this for you. For more information for this exam material, you can refer to the DSM-5 and all texts assigned for this course.